how you want insertions and stuff.
Yes.
Insertion origin.
How do we find it? What are we looking for? Rectus abdominis.
It's a superficial.
The easiest one.
It's the superficial
Start easy.
abdominal muscles.
Yes.
It's down at the pubic crest and pubic symphysis, and it goes all the way up to the xiphoid process.
Yeah. You guys all know the mean xiphoid process?
Yeah. the little hook
Very,
on the end of
very
the-
noduly bit of the sternum. Yeah. Also attaches to those. Sorry.
Okay, you're okay.
Also attaches
Sensitive to cold.
to the rib 5 down. 5
to 7.
to 7, is it? Yeah, 5 to 7. Oh, yeah. Where are you looking? So if you're looking, beautiful stomach here. What are you looking for? What's going to quite obviously show you
The lines.
Yes, it's the most. It's the easiest one.
You know, the six pack.
Essentially, your 6 pack. Yeah, very easy. Main belly of the muscle, obviously straight through the middle. To be fair, you're probably, out of all of the abdominal muscles, this is the one you'll treat the least. You'll mostly be treating intercostals, obliques, diaphragm. The rectus abdominis itself, because obviously it overlays over your abdominal cavity a lot more than the other ones, the treatment that you do on it is very light, and essentially it is mostly based off your relaxation style. Because because obviously your digestion is in a specific movement, we cannot necessarily strip or cross fibre the rectus abdominis, because you can backflow the digestion. Okay, so when you are doing it, you can do longitudinal stripping, but it's this way and this way. Okay, yeah, it's the same with cross fibre at the bottom here. You can come this way, this way, this way. You just have to be aware that your direction still has to be in the direction of the organs. Okay, yeah, so you have to clockwise. So you all are generally, we always recommend standing on the side of the table. Tends to be because if you're right-handed, most people are right-handed, so you'd stand on this side. If you're right-handed, we generally, because this motion, if you're right-handed, is a lot easier than trying to do it on that side. Unless you're left-handed, then obviously you can do that side. I'm right-handed, so I prefer the side table. Yeah? So yeah, it is, and again, because of it's at a lot lighter pressure than the other ones that we will do, because again, you're pushing directly down into the abdomen, right? And we can't stop that. Like, there's nothing you can do about it. So it's literally, except you can strip and kind of cross fibre that, depending on what you're doing. But mostly it's kind of incorporated into what would be almost like your warm-up, which you would just do your normal, when we're doing all these, your warm-up is literally just like your relaxation. You're kind of bringing in that kind of motion, circular, that is literally how you would warm it up, and that kind of, it kind of incorporates your rectus abdominis, because again, you can't apply the pressure because there's nothing underneath it. Yeah, you can do the attachments though, obviously. Yeah, so, and again, I normally kind of do all my attachments at once, because obviously you're going to be doing all the ribs anyway if you're doing obliques and stuff. Same if you're doing diaphragm, which I normally would as well. You're doing xiphoid process. I always get xiphoid and zygomatic confused, because that's your zygomatic process or not, and that's your arch, is it?
Not zygomatic notch, isn't it?
No, I think it's not. Technically, not. So then they're very similar words. My brain just goes, which one is it? So yeah, I generally do all my attachments as part of with the rectus abdominis kind of incorporated in. And then they would do their own pubic symphysis attachment with your hand. Which if you're cueing them for...
Yeah, what is your cue?
It depends on my person. Males, a lot harder to do than females. Obvious reasons.
Yeah.
For a male, especially, the easiest way for them to do it themselves is to actually hold themselves down and then come down this way. It's really the only way they can get to it, because they actually have to almost pull everything down so that they can actually get to it. And it's very uncomfortable for a male, especially. Thankfully, most of the ones that need it are female, so it's because mostly you're treating around post-pregnancy in terms of
Okay.
pubic symphysis.
Why
So
would you treat it on a male then?
Hey?
Why would you treat it on a male then?
the only time I might treat it on a male would be specifically if the diaphragm or rectus abdominis was really bad and
Okay.
you needed that release, because obviously it attaches there.
Mm.
So if working everything else wasn't quite enough, then I might get them to do it themselves. I would never, I do it on a female, I don't ever do it on a male. Always get them out to themselves. Purely because obviously it is, on a female it's not quite as bad because, you know, I'm also a female.
Yeah.
I know sometimes I'll refer it to a male colleague that treats it. Again, there's not many though. Not on the Waikato anyway. My tutor in Auckland does it for males. So in his clinic we would refer to him to do it. Because obviously it is better if you know what you're doing versus them just kind of friction it themselves. But again, it would only be really if you weren't making enough change and you felt that the only way to get it would be to release that tendon.
Okay.
Some people, it is, unfortunately. Yeah. For females, obviously a lot more important, especially post-pregnancy, because obviously with the pregnancy hormones and that, all those ligaments lax. And that can gap. So treating that can become quite important. And sometimes they'll find that it's comfortable afterwards and they'll start treating themselves more regularly again. So it kind of depends on the person. Essentially, you can do the same thing for a female. You can just say, you know, if you slide your way down right through the middle and it's literally, you'll hook under and there's like a little nodule, if you guys do it on yourself, and that's where you want to be. Right in the middle. So if you go down, and then you'll kind of hook under and pull back up, and that's where you want to be. And then you just literally friction that.
Okay.
You can do it when you're on the table, so that we're not all kind of like staring at each other doing it. But I do want you to practice it.
Someone up there.
Because yeah, it obviously does look a little strange. So generally, sometimes I'll explain it to the client and they'll do it when they get home. If they're some clients will be really quite self-conscious about it. Or I'll turn away and say, do you want to see it? If you have any trouble, let me know. And then once I've done it, I'll come back. Because again, some people get very self-conscious about doing it for other people. Because it does look a little like you're playing with yourself. So some people get a little bit like, oh, this is a bit weird. Yeah.
Gus is like, yeah, I'm not demonstrating them.
Yeah, no. So you can all do it like when you're by yourself. If you have any, and again, most people it's very obvious because one, it's tender, and two, like I said, it literally you'll hit it and it's like you're hitting a ridge, and that's where you want to be. As long as you're right in the middle, and it's quite distinctively bone, and it's normally quite distinctively tender if you get the right spot. So if it's not tender, you're probably in the wrong spot.
So you're down, hook under.
Yeah, so you actually need to, like I said, if you go down the middle, you'll kind of hook over the edge. You almost pull back up onto that, lead to that little nodule, and that's where it'll be tender. If you're on the top, it won't be. It has to be kind of almost hooked under. Yeah, and that's where it'll be tender, because that's where it attaches onto, like right at the bottom. It's not on, like, this part of it, it's literally under. Yeah. So you've got to hook around. Okay, so that's attachments for diaphragm rings and all.
Curious now.
So yeah, so
Could we
when I
go-
treat it on a female, I would treat pyramidalis, which of course attaches there, but then you actually have a little bit of muscle coming up, which is literally in your V.
Yeah.
So I would literally be treating the muscle in there, which is why I would treat it on some females post-pregnancy. Again, they can kind of treat it themselves, but it kind of depends. Normally I'd only get them doing the actual attachment themselves, which of course is obviously right in there. The rest I'll do myself. Yeah. But you guys don't have to. You just need to be aware that there is a muscle there. Okay. Obliques. Internal, external. Who wants to?
Hands in pockets, hands on tits.
Essentially, yeah. My tutor always used to say hands in pockets. Which one's that?
Internal.
Yeah, and she always said model pose.
Oh.
But, yeah, so that's external, internal, external. Yeah. What are the movements? What's the difference between the two? They both actually flex to the same side.
Yeah.
The rotation is different.
External rotates to the opposite
Yeah.
Yeah.
side.
So external rotates across. So if I'm rotating this way, it's this external oblique and this internal oblique.
Contralateral, that's it.
Yeah. Internal oblique rotates to the same side, external rotates to the opposite side. So you always got two obliques working together across when you're rotating. Same side, lateral flexion. Yeah, so they both laterally flex to the same side. What ribs?
6 to 12.
That's internal.
Can you
Internal.
differentiate?
Oh, external,
Is
external.
5 to
external.
12. Is internal.
External's the bigger one.
Yeah, 5 to 12. And then I thought the internal was 6 to 12.
I think internal's only the bottom, like 3 to 4.
Internal is 10 to 12.
Yeah, it's only the bottom 4, is it?
Yeah.
Yeah, for internal, it's bottom 4. External basically will be in line with your, yeah, so if you come across, you'll get the right rib for external. Same with diaphragm. All the ones we do today essentially will be in line with the bottom of your sternum. They are the ribs below. If you're up, you're in intercostals. Obviously intercostals go all the way, but you know, there's no obliques up here. That's serratus and intercostals.
Oh, that's because your
Makes sense?
yeah, because your diaphragm's your internal 6 to 12, isn't it? I might be wrong. Sorry.
Yeah, diaphragm essentially attaches all the ribs and then the lumbar upper 2 vertebrae.
Yeah,
At
1
the-
and 2.
Yeah, on anterior and then the central tendon. Yeah. So we always section it essentially, even the diaphragm, into left and right when you treat. We always treat one side and the other, central tendon. So you can treat the central tendon, which we do. It's just friction essentially. We'll go through that. Intercostals, you can also do intercostals in prone partially as well. Generally, to do them well, you have to do it in prone and supine to get your full coverage. Internal, external intercostals. What's the difference?
Inhalation and exhalation.
Yes. Which way around?
So smart.
Yeah, lovely book
myself.
reading. Great reading. Keep going. Seeing as nobody
And I'm
else is
still
actually-
hesitant.
Yeah.
The external assists with inhalation.
Yes. So external, go that way.
I can get
They
confusing
lift
now
up.
because it's like
Internal. Yeah.
internal.
Pretty easy. Internal,
In-
inhalation, external, exhalation. Makes sense. Right. Also, you'll internal, like most people, internal are predominantly active through the front, external more the back. Yeah. We already can't talk about the diaphragm attacks. Okay. Treat. Essentially, it's the same as what these ones again. We don't. Diaphragm we use breathing. These ones we don't really use movement, except for when you can use breathing. Breathing is our movement for these ones. Like I said, rectus abdominis and that you kind of do with your warm up, and you've got to be careful of your direction. Obliques, obviously more lateral. They are more kind of on the ribs and through the side. Internal, we treat all the. You're really cold. I'm really cold. Sorry. Internal, they actually come into what's that ligament called?
Inguinal.
Inguinal. Horrible word. Inguinal ligament. So we actually treat. You know how it's very similar line to where you would treat. Iliacus. It's along that line, but it's tendon. You can generally feel the difference. So the difference being is obviously we're not going to be hooking under. It is literally straight down, and you can feel it. Sorry, I know they're cold, aren't they? On most people, and most people, like if I was treating one side, I might pull it down slightly so I can get it slightly more of that, because you want that whole kind of front section here as low as you can, as that comfortable. And so you'd literally come in, and most people, yeah, like for her, it's quite prominent. It's normally quite prominent, and you can friction that all the way along, and then you'd continue round the internal, and then come up onto your ribs. So you just got to think of your direction. So internal, if you're lengthening, essentially you'd be coming around this way,
Mhm.
external this way, and you strip through the ribs as well. When you're doing obliques and intercostals, they do, again, you're kind of interlinking them quite a lot.
Mm.
They kind of, obviously they're all overlaid, so you just got to think where, well, with any muscle, are you trying to lengthen it? Are you trying to shorten it?
Mm.
Again, if there's a rotation,
Mm.
you'll be wanting to lengthen one side, so you'll be long strokes on one side, cross fibre on the other. So you do have to remember, or look up beforehand, where your attachments are, so that you can get the right fibre direction side to side.
Yeah.
Because most people, you'll be doing opposite.
Mm.
So you say, for example, you'll be lengthening internal, external here, and you'll be cross fibring external, internal here. So you'll be doing opposite on each side. Makes sense?
Mhm.
So just bear that in mind. But essentially it's the same. These ones we don't use breathing or anything, so it's literally frictioning attachments around the ribs, and then doing your long or cross fibre strokes. To be fair, we mostly do long strokes on the side that's short. Cross fibre and these is not as effective because you can't get them to actually do any movement with it.
Just a question, because I usually do it with them when they prone,
You can,
just because it's
you
you
can,
can get a better.
you can.
Grip.
Yeah. If we can show them. So prone essentially is because you can swoop around and come back. Normally, I do. Depends what I'm doing.
Mm.
I would often, if I was doing work for breathing, for example, and I wanted to get to diaphragm, I would normally start with my prone. Do mobilizing stuff through the back, do my intercostals and my obliques prone, turn them over, finish the attachments, because you can't reach all the attachments in prone. Because you can't do the tendon stuff here in prone, because you'd literally be reaching around into there.
Yeah.
So I would do all I can prone first, because it kind of helps warm it up, turn them over, finish what I haven't been able to reach supine, and then diaphragm, because obviously you can't do anything with diaphragm face down. So I would normally do it in the 2 stages. Yeah. So same with intercostals. Like you can't reach all of the intercostals in supine, and you can't reach them all prone. So you either have to do half and leave it at that, or you have to do face up, face down. So I always do face up, face down, but yeah. So you can, yeah. For this demo though, face up, obviously talking attachments, I would do them face up. But like again, a lot of the actual stripping that I would do would be, because when they're face down, you can obviously use that kind of pulling motion, which is it's more comfortable too for most people than like if you're trying to strip this way here, it's actually very awkward. Whereas if they're face down, as long as you tell them what you're going to do and you're not like, and you're on the right place here and not like coming up onto their boob, you can get a really nice strip coming around there and this way as well, pulling up over the opposite hip each way. Yeah. In this position, I actually tend to do it this way. If I was going to strip, I tend to use the back of my hand as well. I can do it that way. Or opposite. Work on the opposite side.
Yeah.
Because trying to do that I find really difficult, but doing that easy. So it just depends on, you know, your flexibility and your preference really. Yeah. I would treat the attachment here this way.
Yeah.
But for stripping I'd either do it upwards or opposite side. So again, you do tend to sometimes end up flip-flopping a little bit with these ones, depending how many of them you're treating on as well. Same with intercostals, because essentially with intercostals, again, you can cross fibre intercostals, which is essentially going between the ribs down, or you can obviously do little tiny long strokes up through them. It takes a hell of a lot of time. And mostly if I was doing that, it would be through the back of them, on the back side. So face down, doing it, working from here, almost round this way. Yeah. Don't actually, the only, because it's essentially the only real part of intercostals you can treat well here is the very front aspects here. I also treat them obviously up through the chest as well, which of course you can't do face down. So you do have to treat them, unfortunately, face up, face down. And if people are comfortable, I will actually do the attachment all through here as well, as much as you can. Normally, what I get like a female to do is just literally put their hands and pull their breasts out as far as they can, and I would treat as much as they can expose through here, and then same reverse, pulling out, relaxing the arm out, working through here, and then turn them over and work through the back. So
Would that
that's
be
the easiest way.
real tender?
Yeah, really tender.
Yeah, I
Really
could
tender.
imagine.
That's really tender. Once you guys do it, you'll know. Yeah. But treating the attachment, it's the same obviously when you're doing pecs. People don't treat these attachments because they're not comfortable putting their hands on someone's chest. If you're not comfortable, like I said, get them to hold it. I actually drape it. I don't have a towel, but you can actually get them to hold the towel here and pull the towel down, so that you've created like a boob tube style, but it's like here and it goes out like this. Yeah.
That's,
Or you can,
the big wraps, what do you call them, like a sarong type thing.
yeah, they're quite
They
good for
make
that.
a really good.
Yeah.
Yeah, because they're movable.
Yeah, because there's heaps of it and it's easy to move. And I just get them to do it themselves if they're uncomfortable. Most people though, most females, if it's a female therapist, they'd be quite comfortable with you treating the attachments through the towel. I do like to strip through here though, which is why I tend to ask them to make that and then just hold themselves out as far as they can, because I want to be able to treat all of this. Yeah, but obviously you don't want to be trying to do it through breast tissue because that's tender or more tender. These muscles are tender anyway, so if you're then trying to treat through more breast tissue, it's going to be more tender. So as much as they can, get it out of the way and open up as much here as you can, fully treat through there. Intercostals, pec major, you want to be treating those, and obviously we'll go through pec for that one, but yeah, you do want to be doing intercostals through here. Yeah, especially for upper chest breathers, intercostals through here be horrible. Yeah. Even if you're only frictioning through. But even just stripping them out is good enough. And I can come around and show you guys that draping with the towels and people. But yeah, even just doing, like I said, even just frictioning the attachments of pecs and stuff through there. And again, if you're not so confident doing actual stripping, because some people find that more invasive. Sometimes I won't like physically strip. Sometimes I might literally just friction my way, because then they feel it's a bit more controlled. Yeah, and it's less invasive than kind of stripping out towards their breast. Yeah.
So how can you tell the difference between, like, because I feel like that would be really sore on me at the moment. How can you tell the difference between like normal good pain and like actual not good pain, if you get what I mean? Like,
If it's too much,
yeah.
well, they'll tell you. Most people, especially people with breathing problems, they'll have a lot of trigger points as well, through the intercostals and through pec minor. So if you're treating for breathing, very important muscles to do, you have to take it very slow. So I mean, to start with, I might even just start with a little bit of fascia release through the chest, and that'll be it. And get them to do some kind of fascial kind of stretching, opening themselves before the next session, and then slowly build in. I wouldn't, on most people, I wouldn't jump in and like start stripping the chest out. You kind of have to build it up. It's the same with the diaphragm. Most of the time, you know, the first session that you do on a diaphragm will be very quick and very short. Because most people, especially to start with, you know, you go in there once and they're like, okay, that's enough, get it out now. And if they've had breathing problems, myself and like you with asthma, they'll hate it even more. Because they will literally feel like they're having an asthma attack sometimes. As soon as you put any pressure on there, they'll feel like they can't breathe. Yeah. Any questions? No. Cool. Again, those ones are pretty self-explanatory because you just have to follow the muscle. Diaphragm is probably the one that's the hardest of all these. In terms of, like I said, you've got to really tailor it to the client. Some clients you'll be able to get in quite well. Not at all. One thing to think though, when you're doing obliques, you do actually need to treat the attachment right around the ribs. So when you can actually friction all the way around. So friction, and it's literally you're dropping. I like to do it this way, but you can do it however you like. You can kind of do it this way as well. I tend to do it this way. You want to take the skin from the very edge of the rib and drop onto that, like the ridge of them, and actually friction. People forget that part and they just treat it on the ribs, but you actually want to friction all the way around, because then it also leads into diaphragm. If you're doing diaphragm, that gives them like a nicer intro to diaphragm. Okay, so you can treat the central tendon as well. Again, it is. I tend to do it kind of as top and bottom half, because again, if you you can't really do much pressure with it, because obviously it's not down the and if you go like that, it's not very comfortable. So if you go down like this, they probably will hate you a little bit. So I generally do top up, and it's literally just sinking onto that tendon, and it's literally just a back and forth. You can also do like little fascial stretches across it as well, unless they have a separation, which again is normally here. So only kind of 2 to 3 fingers here. You can normally feel it. You should be able to feel it. Most people, obviously, then you wouldn't be wanting to pull apart because it's separated, and you don't want to be sticking your fingers in the hole. But you can release above it, but nothing below. Only above. Most people, it starts here. It's normally this section. Some will have one finger above as well if it was really bad. Well, you're not like in there.
No, anywhere near it. I just
okay.
don't know.
So you can. That, if the rectus abdominis is really tight, the fascial work across that is really good. Again, not if they've got a separation, but most people that have a really tight rectus abdominis wouldn't have a separation. That's normally males. When I have males, that would be normally what I'd do, would be fascial work both ways, obviously, across that central line. You can obviously do, up it as well. As long as I always go this way just because of that way, just because of
The direction.
direction. So that's the main thing to bear in mind, is obviously if you're working over there, just the direction. In terms of diaphragm, we always treat side by side. The best way to think about it, if where you're going to be treating, if you pop your fingers just around the line of their ribs there, it is essentially where you're going to be treating. But sometimes it is easier if their knees are, we don't have very big bolsters here. You want their knees to be relaxed, so sometimes putting a bigger bolster can help them relax a little bit more, but you don't want them having to hold their knees up, so that's going to make them contract. So for now, if we have another pillow, we want to make it as comfortable as possible.
Yep.
So
Yeah, some thicker pillows.
As I
around.
put the foam rollers under a pillow.
oh yeah, that would work too.
There's 3
I'll
pillows.
just get you, yeah, it's good. Just so that we can kind of, relax everything else as much as we can. We're going to get them to, first, has anybody had it treated or treats it? You do. And you treat it or you've had it done?
Both.
Both. Okay, cool. Nobody else?
A little bit last.
Yeah, we did a little bit.
Just
Or a little?
Like rocking and I think it was like heaps of
Yeah,
sideline.
just this one, you mean?
Yeah, and heaps of sideline getting underneath the ribs. It was like the very last thing we did, and all of us were like, yeah.
So did you do it in supine though? Yeah. Or was it all being
A little
inside?
bit,
I
yeah.
started on supine and really sideline.
I am supine.
I was going to say, how do you use breathing in sideline?
No, it wasn't not breathing focus at all. It was more like, you're just trying to get under the ribs and stuff. I don't know what we were doing.
I don't know.
We did a little.
I've never done diaphragm in sideline. 'Cause-
No, it doesn't release.
no,
Yeah.
I wouldn't suggest doing diaphragm in sideline. No, I wouldn't. No. Do it in supine, please. Okay. So essentially what you're going to be doing is you're going to be using their breath. So they're going to take a deep breath in. With their breath out, you're going to sink in and under. That's the best way to describe it, maybe? Yeah, so you're aiming. So obviously, there are two things that you need to do. First is the attachments, which is obviously normally what you want to do first. And that on the insides of the ribs. So sometimes people can treat their own by tucking in and under. Don't like it, but you can. And then frictioning. So essentially that's what we're doing. So in this position, we're going to be like breath in and you just let them come out. As they breathe out, you're going to be pushing kind of up and around and frictioning right under that edge of the ribs. And you're going to work all the way down and then you come back to start back at the top. To treat the muscle itself in terms of like your, yeah, it's not really stripping in the sense of stripping, it's like it's very small. You're just going, instead of hooking, instead of aiming kind of up into, you're aiming to the space behind. So you're aiming back in here, and you're, again, they breathe in, you breathe out, you come in, essentially you do a scoop, you hold the pressure if they can, they breathe it in again and push into your hand and you hold that in, then as they breathe out, you go deeper. If you do the first one and they're struggling, I'd come out, go in, come out, go in, come out, go in. Ideally, obviously, you want to progress deeper. Not everybody you can start with. Sometimes it takes a long time to be able to do that. But that would be the kind of stages that you would be trying to progress through. And it's just little, it's mostly, you can do a little scooping move. Again, if they were quite comfortable with it, I would do like actual little scoops. However, most people, you're not going to be starting with that. You know, you're literally just going to be pushing in, coming out, pushing in, coming out. But further down the track, when they get more comfortable, on some people, you could start to add little bits of movement. And that's when, you know, you've been working with them for a long time. Yeah. And again, it's not like a big movement, it's just, it's little ones, okay? I don't tend to do them this way. I don't like doing the attachment that way. I find it quite invasive, yeah. And most people, it's too much, especially for the first time. If they're treating it themselves, I would give it home care for somebody potentially to try and, so breathing in, and then as they breathe out, sink in, and then come out. As they breathe in, as they breathe out, sink around, and then come out. And that would be it to start with. And then if they can do that, you can start adding little frictions. And they can start treating those attachments themselves, which means that you'll be able to treat it better and better and better. Most people, it is very uncomfortable to start with. Some people, not so much, depending on the person. People with, like, even just doing that for me is like, it's horrible. So it depends on the person. And I do that on myself and it's still horrible. So, you know, if you've got continual breathing issues, then obviously it's going to be harder to ever progress that. But it's needed. Asthmatics, they really ideally want to be doing it on themselves because otherwise their breathing gets worse and worse and worse. The more you can do it on them or they do it on themselves, the better chance they have of their breathing improving. Especially if they're actually trying to work through deep breathing, things like that. Okay, let's give it a go. Most people too, you'll find generally the top portion is actually way more tender than the bottom, obviously because you've got rectus abdominis as well. So it's easier normally on the bottom part than the top part, because obviously there's more muscle to get through. There's, yeah, makes sense, but just sort of point out if you go, oh wow, that's tight, it's normal. The first section's more difficult. So, take a nice deep breath in for me, and as you breathe out, I'm going to sink in. So as she starts to breathe out, you're just going to sink in. And for the attachment, I just come out with the next breath. If they're comfortable and you can friction, obviously you can stay in and do a little bit of friction. It kind of depends on the person. So, she's not too bad. So I could do a little bit of friction there if I wanted. No pain, because she's fine.
Do you friction when they exhale as well? Like do you keep, or do you release?
So generally you sink in on the exhale, and then if you're in a friction, you can friction on the inhale and sink further again on the next exhale if they're comfortable with that. Otherwise, I would come out with the breath in, because that's normally when they, especially if you've got a breathing problem, they'll right out. So some people, you won't be able to hold any pressure in with that breath in. Some people you can. Yeah. So she's quite good, so I think she probably go, I was being quite nice, I'm probably a little meaner. You can, if you need support, obviously you can use both hands if you need the kind of the pressure. Kind of depends what fingers you use. See for her, I think she get right up and under there. She's really quite good. See, I can actually sink right in there. And I can stay in as she breathes in. So I could actually, for her, I could add a little bit of a scoop there, if I wanted. You can, like I said, you can be a little bit meaner. I'll do this side, because I've kind of already done it. I don't tend to, but that's just because of my client base. You can do the attachments this way. Okay. Depends on what fingers are strong as well. I'm okay with kind of like a lateral pressure on my fingers. Some people kind of can't get that lateral movement. So you can, you can sink around with your thumb. Yeah. Some people, I have a hypermobile thumb, and obviously putting that position is really bad, so I don't like to do it, but you can do it that way. Yeah. And you can also do it that way, but again, this way is quite invasive, so I don't tend to use it. But again, if you are struggling with strength, you can. Again, I don't like to do it, but you can. So you literally would be sinking, but yeah, see, it's not as comfortable, and you tend to use your nails a lot more. So I don't tend to use it. I would suggest trying to get that sort of sideways pressure with your. I tend to use that finger. I'm not sure why I tend to be strong, but using your fingers this way or your thumb that way, not this way. This way is not very comfortable. And essentially, it's just practicing getting up and under, and then working with their breath. That's really all you do with it. Have you learned anything else for that?
With that release? No. Oh, just the breath release.
She's like, are you ready for this?
Yeah.
Bottom and top.
Do you, with the in here or the compression on the ribs or both?
I don't like the compression of the ribs though, because it feels unnatural. Whereas the breath release, they don't expect it. It's easier because that anticipation is not there.
Yeah.
So for I just think some clients will find that as.
I find that one, I don't like that one very much.
It's almost like it's causing restriction
Yeah.
more than anything else. Where the other one is you're just focusing on where the breathing's going.
Yes, you mean you're following their breathing? Yeah. So you can do that, and we'll get them to do this first, I think, and then we can maybe add that. You can work. Yeah. We'll see how we go. Well, you can work with the breath a little bit more, and there is, like I said, there are some. You can get them doing different types of breathing, and you can also do slightly more. But we'll do this to start with. See how we go with this, and then we'll build on from there. I think. Yeah.
Would you use oil at all to do this, or will it
I
be?
don't. No, because you need like the grip to be able to come around. You can use a tiny little bit, but generally, no, not really. No.
Okay, no.
Not really. I like to be able to grip, especially if you're doing. See, if we all comfortable with this, if we do some of them, you can do a bit of stuff with their breathing and that way you kind of get them doing different types of breathing, and then if you've got wax on, you just kind of slip and slide all over the place. We'll do this first, and then we'll see how everybody goes. So pick up